I thought I'd start by asking you a poll question, which we're going to repeat at the end. And this is to ask you, what percentage of patients do you think will present with an early stage cancer, so stage 1 or 2, in 4 years' time? So I think they're just going to bring that up. And then I'll see if I can change your mind. Okay, very optimistic. Okay, so we'll remember that headline figure of 48%, 58. Oh, there's some pessimism coming in. Okay, but let's call it there. So before we discuss really developing a cancer strategy, we have to look at some of the challenges that we're facing in the UK just now with cancer services. So we currently see about 375,000 new cases of cancer every year in the UK. That's about 1,000 every day, and that's predicted to go up to over 500,000 a year by the year 2040. And the reason for that is it's being driven by our increasing population, our ageing population, and our increasingly unhealthy population. And we'll discuss some of the risk factors that are driving this up. So for most of us in this room, that means a lifetime risk of about 1 in 2 or 50%. Now, while stage is still the most important risk factor for most cancers in that the incidence gets higher as we grow older, there has been an increase in early onset cancer, so cancer diagnosed under the age of 50. If you look globally, during the last 30 years, it's gone up almost 80%, particularly in lung and stomach, breast and bowel cancer. And we'll talk about some of the reasons for that. But it seems to be being driven by a number of lifestyle factors that are also important for the older age group. So smoking, being overweight, lack of exercise, low physical activity, and a high fasting glucose. So that's something that's new, that's appearing on the risk factors, but that's something we could do something about if we find that someone's got an elevated glucose. But I suppose the take-home message is that up to 40% of most cancers are preventable, and we'll see why that is. So we're in a stage just now where, due to decades of underfunding, we have NHS services that are seriously underperforming, and we have long delays to both diagnosis and treatment. So we're basically not detecting cancer early enough, and that's giving us one of the worst cancer survivals amongst OECD countries, the worst cancer survival in the G7. And if we compare ourselves to Europe, if we could get our cancer survival up to the average cancer survival in Europe, we would save about 18,000 deaths a year. Some of you may have seen some data from Macmillan yesterday, which is comparing our cancer survival in England against Scandinavia, so Denmark, Sweden and Norway. And our cancer survival for breast and bowel, lung and prostate cancer is where they were somewhere between 10 and 25 years ago. So the scale of how far we've fallen behind is absolutely enormous. We seem to have scrapped most of the cancer targets recently. We're left with 3, of which these are 2. So the one on the left is the faster diagnosis standard, and that's where, for somebody referred urgently, we're meant to either reassure them they don't have cancer or confirm they do have cancer within 28 days. The target's 75%. I think we've met it in 3 months since it was launched in early 2022. The graph on the right is the 62-day target, where we're meant to treat people within 62 days of urgent referral, start treatment. And the target for that is 85%. And it hasn't been met for years. The most important thing to take away from these graphs is that these are only for urgent referrals. People on a non-urgent pathway are waiting far longer than this, and that's the real tragedy. And we've got no idea just how long they're waiting. So, how can we improve early cancer detection? Because that really is the key to getting better survival and better outcomes. So if we look at it from the patient's perspective, diagnosing cancer early is more likely to pick it up in an earlier stage where it requires less treatment, less invasive treatment, and that means people can get back to their family or back to work more quickly. But the most important thing is they have better outcomes, they have a better survival, and they have a better quality of life. And that's the case for many, many cancers. If we look at it from the employer perspective, then you've got less workplace absence, and we'll come back to trying to put some numbers on that. Less side effects, that means they're less likely to be absent for work, less presenteeism, as we were hearing about early, and reduced disruption from loss of key employees. It also means that the treatment costs are likely to be less. So that's good whether you're running a trust or whether that's an insured service. And there's less death in service benefits. And we can draw all of these benefits for the employer and the employee together and look at a return on investment if you actually invest in screening for your employees. And we can do that quite easily. So if I tell you where we are with early cancer detection, before the NHS cancer plan was abandoned, the target was to try and get us up from 50% early cancer detection to 75% in 4 years' time. And that's why I was asking you where you thought we would be. Last year we got to 58%. I know COVID has got in the way here, but you can see that we've actually made very little progress. And I think with the way that we are at the moment, with having less doctors, less nurses, less scanners, less beds per head of population than most developed countries, I can't see how that's going to change dramatically. If we look at this table on the right, in purple is where cancers are mostly diagnosed at a later stage. So pancreas, lung, bowel cancer. Still got to make big inroads in trying to detect those early. The ones in green, green is early cancer detection. So at the bottom you see we're doing quite well in skin and breast, bladder, but we've still got big improvements to make. So what kind of things do we need to consider? Well, we need to educate the workforce in terms of the risks of breast cancer and the signs and symptoms. We need to start moving towards prevention. We've heard a lot about prevention today in various talks, but actually it's one thing identifying the risk factors, it's another thing trying to instigate behavioural change and then to maintain that behavioural change. And we heard from Kitty Tryon at Vitality about how they've succeeded, but I think it's still a big challenge for most companies. Cancer screening is obviously one of the ways we can pick up cancers early. You have to be careful though. There are a lot of tests currently being sold under the guise of screening when they're actually not validated screening tests. So CEA is not a screening test for bowel cancer. CA125 is not a screening test for ovarian cancer. So you must be using tests that pick up the cancer early when an earlier intervention will have a better outcome, and that's what you need from screening. And then when people get symptoms, we need to make sure that they get into diagnostic pathways quickly. So no GP referral. The pathways are streamlined. They have the tests and as few consultations as possible, and it's possible to do that. So signs and symptoms. I had a big bugbear about this during lockdown, that you cannot diagnose cancer or even have a suspicion of it in a video consultation. You need to go and see someone. They take a history, then they examine you. History is meant to be 90% of making a diagnosis in someone. and you do that before you examine. So I think anybody who's seen their GP and they're worried about cancer, they really need a face-to-face consultation. I think that's why you're seeing this massive increase in private GP appointments now, because people just can't get to see their traditional doctor. We can use lots of infographics like this to try and get the message about cancer awareness over to people, and you can do this for any of the common cancers. And I think that's a good way. If you're running a screening company, a screening program in company, then you can support it with lots of different ways to communicate the messages that you're trying to get across. So coming back to risk, so it's CR UK that have come up with this figure that 40% of cancers are preventable due to lifestyle and environmental factors. And we can now estimate the risk of common cancers. And that allows us to get into risk reduction, but also risk stratified screening. And there's quite good published evidence in common cancers that risk stratified screening, which is where you increase the amount of screening or start it at an earlier age for those at highest risk, tends to pick up more of the aggressive cancers, where you're likely to have a bigger effect on outcomes if you pick it up and treat it earlier. So here's some of the risk factors. I don't know how many of you know that alcohol increases your risk of breast and bowel cancer. Smoking is involved not just in lung cancer, but it seems to be a cofactor in cervical cancer as well. And by that I mean, if you smoke, then you're less likely to get rid of an HPV infection should you develop it. And you can see in this column on the far right just what percentage of those cancers are preventable. So almost a quarter of breast cancer, half of bowel cancer. You know, there's huge things we could do if we managed to start focusing on the early part of the pathway and thinking of investment in cancer prevention rather than thinking of it as an expense at the other end of the pathway. So thinking about cancer screening, preventative cancer screenings are still a highly valued employee benefit across all age ranges. And it can be offered in several different ways, as a flexible benefit, as a bespoke company-funded campaign, and you can really structure it to whatever the demographics and whatever the requirements of your own workforce are. Talking about risk stratified screening, this is something that I think is a good way for larger companies to offer screening, and it's where you offer all the employees a cancer risk questionnaire. We can do that at the moment for 6 common cancers, and it identifies those at higher risk of each of those cancers. So you can target funding to screening those at higher risk. But everybody gets access to an education hub where you can learn about the risk factors, the signs and symptoms, and so it's a kind of whole of workforce education, but targeting screening to those at highest risk. And that's had a lot of interest from a lot of key companies, and in fact you heard from Katie Trown at Vitality just before lunch, and they launched that with their members last year. So when people get symptoms, we need to make sure that we've got fast access, streamlined diagnostic pathways. So no GP referral. You saw on the Helix slides just earlier a number of different pathways, not just cancer, but taking out the GP, because actually that's just slowing things down. If you have strict criteria about who gets into these pathways, they don't need to see their GP. And I think that's gradually being accepted. We've known for a long time that most people that use their private medical insurance haven't actually seen their GP, even though they say they might have. These types of streamlined pathways are more sustainable, but they're also lower cost. So this is one way of looking at value-based healthcare, and I think cancer pathways are a really good example of this. For employees working with cancer, we heard in a report just earlier this year that they have an average of 15 weeks absence from the workforce, and that's costing UK business a huge amount of money, £1.6 billion. And that's just from physical absence, you know, not taking into account there's been a lot been written in the media recently about Kate and about King Charles, and I think I was asked to write something about it, and I think it's really hard, and I think, you know, having a phased return to work is really, really important, and that will be different for every employee. And we'll talk a little bit about how to manage these patients. But we have to recognise that patients are very different. They will require different amounts of physical and physiological support and psychological support. And it's a time where they feel very vulnerable, not just during treatment, but when they stop their treatment. They feel like they've been released, and that's often when they feel most vulnerable. In terms of general advice, there are a few pointers here. There are obviously your own legal obligations. I think not being afraid to mention the word cancer is really important, and the communication needs to be kept open because the needs might change at different times in their journey. So you need to be flexible and offer continued support. Increasingly, there are companies providing that additional support, and I've just chosen another Cambridge-based company here, Buttress Bayer, and they have a 12-week rehab program focused on nutrition, exercise, and mental health. There are lots of other providers, but I think this is really good, and in addition, these companies can also provide training for employers about how to manage patients like this. PMI are increasingly playing a role in workplace cancer strategies, and we've seen an increased interest in PMI offering screening and looking at risk prevention. We know that Vitality in particular offer exercise and promote healthy living. Nearly all of them are now getting into managed pathways and good management, not what managed pathways used to be, ensuring that patients get diagnosed quickly. And there's a widening of cancer genetic testing. But from 2022 to 2023, cancer claimants went up by 20%. So I think these are patients that traditionally used the NHS, even though they had PMI, but they're now using their insurance. More worryingly is the cost of cancer claims is up 130% year on year. And that's mainly been driven by expensive treatments, medical inflation, and this later stage at diagnosis. If you look across Europe, melanoma has had a 17% shift to a later stage since lockdown. So we're seeing this tsunami now of later stage cancers because of the delays in diagnosis. Looking forward, I think we're going to see an increased focus on cancer screening from insurers, an increase on interest in cancer prevention and how you do that, more and more fast access, value-based diagnostic pathways. I think we're going to see the emergence of a two-tier system where if you don't want to use these managed pathways, you might actually have a higher premium if you want to just have the traditional approach to choosing your own consultant. And I also think that we just heard about healthcare trusts. I think we'll see them increasingly engaging with healthcare providers directly rather than through their insurer. And that's one way of protecting employees that do not have PMI. So I think there are big changes ahead, big challenges. So I'd like to just come back to that Slido question again and see whether you've changed your mind or not. Okay, pretty much a draw. My own view is we'll be very lucky to get out the 50% range. The challenge is so enormous. So thank you.
Thanks very much. There are a few questions, so let's go into those. The first one, you did touch on this. How do you see DNA cancer screening? Is it really relevant, considering sometimes the risk and potential of over-treatment?
DNA cancer screening.
Or
So
genomics?
this is using circulating DNA in the blood. So these so-called multi-cancer early detection tests are all multi-cancer late detection tests. There's very little evidence that they pick up cancers early. That's why the NHS is moving away from the Grail blood test, because it's not hit the markers that they said. It's actually not being analysed and investigated in a way that you would normally assess a potential screening test. So no evidence that they pick up a lot of cancers early.
And in a similar vein on reliability and clinical validity, if you like, how reliable are the at-home screening kits for the various types of cancers? Again, you did refer to this, that some things are more appropriate than others.
Yeah, that's right. So if I pick two, so their HPV is an at-home cervical swab for cervical screening, and there's multiple published studies now showing that a self-sample is just as sensitive as a clinician-led sample, either by a nurse or a GP. If we look at PSA testing for prostate cancer, then a finger prick test at home is just as valid as a full blood sample being taken. So I think, yes, we offer a number of home screening tests, and we wouldn't be using them if they were not validated.
Thank you. A further question. What do you find is the average take-up where checks are company funded? I think it is fairly well known that when screening tests are offered, and this is true on the NHS as well, those eligible don't always come forward, so that can be a challenge. Is there an element of an individual not wanting to know their risks?
There always is, and men are much worse than women. The average uptake for a company-funded campaign is about 40 to 50% if you offer the workforce screening. And if you compare that to a flexible benefit programme, it's down about 5%. So there's a significant increase in the uptake when it's funded.
Interesting. And just finally, do you see AI in playing more of a role in early cancer detection?
I do. I think we've been building a skin cancer AI model using all our own images and data. And I think increasingly we'll see it as a decision aid in terms of triaging people and making sure that the right people get to the right tests more quickly, and reassuring people more quickly that in fact they don't have cancer. So I think it needs to be introduced in the right way and carefully, and all the risks need to be managed, but it's definitely coming.
Fantastic. Thank you so much, Professor Gordon, for sharing that fascinating talk. Thank you very much.